So imagine going to the doctor for severe burning skin pain, like the kind of pain that really disrupts your life. And the doctor listens, takes note of everything you're experiencing, and they prescribe this highly customized high-end medication to cure it.
Right. You apply it, you're just, hoping for relief.
Exactly. But what if that exact cure, the one designed specifically for you, is actually the weapon causing the pain?
Yeah, I mean, it totally shatters our standard expectation of medicine, doesn't it? We rely on this really comforting kind of linear idea of a lock and key mechanism.
Right, you find the problem, fix it, move on.
Exactly. You identify the problem, you apply the solution, the symptoms go away, and you just get on with your life. But biology, well, it doesn't always cooperate with our neat little equations.
No, it really doesn't. And honestly, nowhere does that equation get turned upside down more violently than in the world of menopausal care. Specifically, when we look at localized treatments for the incredibly sensitive tissues of the vulva and vagina. So, welcome to the deep dive. Our mission today is to explore the, frankly, intensely complex world of compounded topical hormone creams used for menopausal symptoms.
And it is complex.
Very. But we aren't just looking at what these creams are. We're zooming in on a crucial, heavily debated clinical challenge. Like, how do medical specialists actually monitor for and manage localized side effects, things like mucosal hypersensitivity and contact dermatitis, when they're prescribing these high concentration customized creams to you?
It's just a phenomenal area of medicine to explore because it sits right at this intersection of brilliant personalization and, well, unforeseen consequences.
Yeah.
And to map this out, we're pulling from a uniquely diverse stack of sources today. We're looking at the compounding pharmacy literature itself, so places like Winona and Central Ohio Compounding Pharmacy.
But we're also holding that up against the major established medical guidelines, right?
Exactly. The British Association for Sexual Health and HIV, or BASH-H, the British Menopause Society, the Royal College of Obstetricians and Gynecologists. Plus, we've got these really strict dermatological protocols for vulvar care and formal patch testing.
Okay, let's unpack this. Because before we can even begin to understand how things go so wrong at the local tissue level, we need to understand the battlefield. Like, why are these highly customized creams being applied to this incredibly delicate vulvovaginal tissue in the first place? And we have to start with something called genitourinary syndrome of menopause, or GSM.
Right. GSM is the absolute foundational issue here. When you enter perimenopause and eventually menopause, your body's natural production of estrogen and other sex hormones doesn't just, taper off. It drops dramatically.
Yeah.
And the tissues of the vulva, the vagina, the urethra, the bladder, they are highly, highly dependent on estrogen. That hormone is actually what signals those tissues to remain thick, elastic, and, well lubricated.
So when that estrogen withdraws, the tissue literally changes structure. Like, our sources describe it thinning out, losing its elasticity, and even the pH balance shifting from acidic to more alkaline.
That's exactly right. The
Yeah.
cellular architecture alters. Without estrogen, the collagen support weakens, the protective mucosal barrier just degrades,
Yeah.
and the impact of that degradation is, it's profound.
Yeah, the guidelines in our stack say up to 50%, and some even say up to 80% of postmenopausal women experience this. And we aren't just talking about, like, mild discomfort here.
No, not all.
It leads to severe dryness, dyspareunia, which is severe pain during sex, just intense itching, and tissue so fragile it can actually tear or split from everyday movement. I mean, it sounds absolutely debilitating.
It is. It really is.
Yeah.
So logically, the standard medical response is to replace the local estrogen. But standard, commercial, FDA-approved options often just contain fixed doses of estradiol in a standardized base.
Which works for some people, right?
Oh, totally. For many women, those work perfectly. But for others, a fixed dose either isn't enough, or it's too much, or it just doesn't address the compounding factors of their specific pain.
Which brings us to the allure of compounding. If you've never heard of it, compounding pharmacies, specifically those operating under 503A or 503B regulations in the U.S., they don't just pull a box off a shelf. They create bespoke, customized medication blends.
Right, so instead of just a fixed dose of estradiol, a specialist can write a prescription for, say, a biased cream, which combines estriol and estradiol.
Or they might add DHEA, right?
Right.
Which is a precursor hormone to estrogen and testosterone to kind of support vaginal health from a totally different biological angle.
Exactly. Or if a patient is experiencing severe active pain, like that tearing we just mentioned, the pharmacy can actually compound estradiol mixed directly with lidocaine, which is a local anesthetic.
Wow.
Yeah, the idea is to provide immediate, numbing pain relief while the hormone slowly works to rebuild the tissue over the coming weeks.
The ultimate goal here is highly localized delivery. You're putting the hormone directly on the vaginal mucosa to restore that specific tissue with the intention of keeping it out of your general bloodstream.
It sounds like the holy grail. I mean, it's like going to a master tailor for a bespoke suit, right?
That's a great way to look at it.
They take your exact measurements and they craft a garment that fits you
Mm-hmm.
and only you perfectly. You aren't buying off the rack. But here is my question. If these hormones are entirely bioidentical and perfectly matched to the molecular structure of what your body naturally produces, why do we even need to worry about your tissue rejecting them? Like, why does this local reaction happen at all?
What's fascinating here is that when a local reaction occurs, it is almost never the bioidentical hormone itself that the body is rejecting.
Wait, really?
Yeah, the active ingredient isn't the problem. The culprit is almost always the vehicle.
The vehicle, meaning the cream itself, like
Yeah.
the stuff carrying the hormone. Precisely that.
Mm.
To deliver that hormone into your skin, it has to be suspended in a base. You can't just rub raw hormone powder on yourself.
Fair point.
And that base requires solvents to dissolve the active ingredients. It needs preservatives to give it a shelf life so it doesn't just grow bacteria in your medicine cabinet, and stabilizing agents to keep it from separating.
Ah, I see.
So when a patient experiences a severe local reaction, it is their delicate, already compromised vulvar mucosa reacting violently to those inactive ingredients. And that introduces a massive clinical challenge, which is vulvar contact dermatitis.
Oh, wow. Okay, let's get into that local battlefield.
Yeah.
Because when the tissue rejects this vehicle, the symptoms are intense. The dermatological sources describe varying degrees of itching, burning, and erythema, which is severe redness. In really severe hypersensitivity reactions, the skin can actually develop blisters and open weeping sores.
We really need to distinguish between two completely different types of reactions here because they require completely different detective work from the doctor. First, you have acute reactions. These are sudden and severe. You apply the cream, and within hours or maybe a day, the tissue is completely on fire. This is often caused by harsh chemicals or, interestingly, by local anesthetics like the lidocaine we mentioned earlier.
Wait, lidocaine, the thing meant to stop the pain, actually causes the pain?
That's the paradox. Lidocaine is fantastic for numbing nerve endings, but it is a known sensitizer for a subset of the population. The immune system basically identifies it as a foreign invader and launches a massive inflammatory response.
That is wild. But the sources also talk about chronic reactions, which honestly seem even more insidious.
They are notoriously difficult to diagnose because chronic irritant contact dermatitis develops at a crawl. It might just be a very mild irritation at first,
Right.
but with repeated use of the offending creams, the skin barrier slowly breaks down, becomes too wet or too dry, the stratum corneum, that's the protective outer layer, is disrupted, and this slow-burning soreness or rawness just takes over.
And our sources highlight one major culprit in these vehicles, right? Propylene glycol, or PG. It's a super common solvent used in all sorts of creams. But why is it so problematic here?
Because of how solvents work. Propylene glycol's job is to dissolve things. On thick, healthy skin, like on your arm, it's generally fine. But on compromised, thinned-out vulvovaginal tissue, that solvent action starts stripping away the skin's natural lipids.
Oh, yikes.
Yeah, it makes the skin hyperpermeable. It essentially breaks down the castle walls, allowing everything else in the cream to penetrate way too deeply and act as a powerful toxin.
So if you're listening to this and you've spent the last 6 months bouncing between yeast infection creams and hormone prescriptions, this is exactly why you might feel like you are losing your mind. A lot of women assume this sudden itching and burning is just a yeast infection, candida. So they run to the drugstore, buy an over-the-counter antifungal cream, and apply it.
Which is often the absolute worst thing you can do.
Because of the ingredients in the antifungal.
Exactly. Those over-the-counter antifungals contain their own heavy load of preservatives and solvents. You're essentially pouring acid on an open wound. And of course, the antifungals won't work because it isn't a fungal infection at all. It's an allergic or irritant reaction to a topical medication.
Though to be fair to the confusion, the sources do note that some women can develop an actual allergic hypersensitivity to the candida yeast itself. But generally, the medical guidelines see a massive overdiagnosis of thrush in postmenopausal women.
It's a very, very common misstep in treatment.
Okay, but I have to push back here. If the symptoms of a bad reaction to the compounded cream, like the burning, the itching, the rawness, are the exact same symptoms of the genitourinary syndrome of menopause that the patient was trying to cure in the first place, how on earth does a specialist actually tell the difference? Like, how do they know if the hormone treatment is simply failing, or if the cream carrying the hormone is actively causing the problem?
That exact dilemma is why prescribing these high-concentration, customized creams can never be a casual process. It requires a highly specific, step-by-step monitoring playbook from the specialist.
Right.
You can't just hand a patient a jar of compounded hormones and say, see you in a year. When a patient reports that their symptoms are worsening, the specialist really has to switch from being just a prescriber to being a biological detective.
I mean, if I'm a patient and my skin is on fire, my first instinct is to just chuck the expensive jar in the trash and give up. But you're saying the specialist has a whole playbook. Where do they even start?
Well, step one is testing the vehicle. If a patient has a history of sensitive skin, or if they are reporting a reaction to a newly compounded cream, the specialist will literally order a jar of the plain inactive base from the compounding pharmacy.
Oh, just the base. No active ingredients.
Exactly. No hormones, no lidocaine. Just the empty vehicle, things like plain petrolatum, methylcellulose, or a neutral vanishing cream base.
And what do they do with it? They don't just put it back on the already burning tissue, right?
No, definitely not. The patient is instructed to apply this plain base to their forearm for 24 hours. The skin on the forearm is tougher and much less reactive. If there is no redness or itching there, then they graduate to applying that plain base to the vulva for 1 to 2 days.
Ah, I see. It's a process of elimination. If they tolerate the plain base perfectly, but they react later when the active hormones are added back in, the specialist knows the medication itself, like the hormone or the lidocaine, is the issue.
Precisely.
But if they react to the plain base alone, they know they need to reformulate the hormones into a completely different vehicle.
Exactly. It isolates the variable perfectly. But let's say irritation does occur, and the skin barrier is now compromised. The specialist doesn't just abandon the patient, they move to step 2, which involves a technique called dilution and something known as the soak and seal method.
I found the soak and seal method fascinating when reading through the sources because it sounds so simple, but the biological mechanism behind it is actually critical.
It is a foundational pillar of dermatological treatment. If the skin barrier is broken, you have to repair it before any medication can work properly. The specialist will instruct you to soak the area in comfortably warm, plain water for 5 to 10 minutes.
Plain water, no bubbles or anything.
No soaps, no bubble bath, no essential oils. The goal is to let the water physically hydrate the cells of the stratum corneum.
But water evaporates, right? Which can leave the skin even drier once you get out.
Which is why you don't just towel off and walk away. You pat dry very gently, leaving the skin slightly damp, and immediately seal that moisture in with a thin film of plain petrolatum like Vaseline. This halts what dermatologists call transepidermal water loss.
And I want to pause here because the sources are very clear on a huge misconception that we all kind of grew up with. Vaseline does not block your pores.
It is a totally pervasive, stubborn myth. Petrolatum is non-comedogenic. At a molecular level, the petrolatum molecules are simply too large to fit inside human pores.
That makes sense.
It just sits on top of the skin. It occludes the surface to trap the water inside, yes, but it allows the normal barrier recovery to happen beneath it. So if a compounded cream is deemed just slightly too strong or irritating, a specialist might have you apply this plain petrolatum first as a protective shield, and then apply the compounded hormone cream on top. It dilutes the rapid absorption and allows your tissue to slowly build up a tolerance.
Okay, but what if that fails? Like, what if you've tested the base, you've soaked and sealed, and your skin is still just screaming at everything? That brings us to step 3, which is formal patch testing. And not just a quick allergy prick test on your arm. We are talking about the North American Series patch test. Here's where it gets really interesting, because the dedication required by the patient to get these answers is honestly wild.
It is a grueling, week-long commitment. If you were referred to a dermatologist for this, they do not mess around. They take panels containing anywhere from 10 to 12, sometimes more different potential allergens. We're talking metals, preservatives, fragrances, rubber additives, and crucially, the specific individual ingredients broken down from your compounded cream.
And they tape them to you.
They taped all of these panels directly to your back.
And you have to leave them there for 48 hours. No showering, no heavy sweating at the gym. You are walking around with a literal science experiment taped to your spine.
Literally.
Then you go back to the doctor, they take the patches off, mark your back with ink to track where each spot was, and they look for immediate reactions. But you still aren't done.
Not at all. Because contact dermatitis is a delayed hypersensitivity. The immune system sometimes takes days to mount its full attack, so you have to wait another 2 days, still keeping your back completely dry, and return to the doctor for the final read. They grade every single spot from a minus, meaning no reaction, all the way up to a 3+, which is a severe blistering reaction.
It is a massive undertaking just to find out that your body hates, say, one specific preservative in your custom cream, which really underscores the reality that personalized medicine is not a passive experience. You aren't just taking a pill, you are actively doing the work.
You really are.
And that leads to step 4 of the monitoring playbook, which is clinical monitoring for systemic creep. Because even though the goal of these creams is to stay local in the vaginal tissue, they are still high concentration hormones.
And hormones are incredibly powerful messengers. Think of the local estrogen receptors in the vaginal tissue like a sponge. That sponge can only hold so much water.
Right.
Once those receptors are completely saturated with the hormone, they can't take any more. Any excess hormone in that custom cream has to go somewhere. It spills over the counter, so to speak, and gets absorbed directly into the systemic bloodstream.
The compounding sources themselves, like Empower Pharmacy, are actually very transparent about this risk. They explicitly state that systemic absorption from vaginal routes can sometimes yield estradiol levels comparable to taking oral preparations.
Yes.
If your whole goal was to avoid systemic side effects, that is the exact opposite of what you want.
Which is why the prescriber must be hypervigilant. If a patient is using these customized creams long-term, the specialist isn't just looking at the skin to make sure there's no rash. They are actively monitoring for signs of systemic estrogen exposure. Things like breast tenderness, fluid retention, or unexpected vaginal bleeding.
Routine pelvic exams are absolutely required then.
Absolutely. To ensure the estrogen isn't causing endometrial proliferation, which is a dangerous thickening of the uterine lining.
So, to summarize the expert view here, a beautifully customized, highly expensive hormone cream is completely useless if the delivery vehicle destroys your local skin barrier. And it's potentially dangerous if the dose saturation causes systemic side effects. The medication has to be monitored from every conceivable angle.
Knowledge and customization are only valuable when they are applied safely. Having a bespoke prescription means absolutely nothing without a customized, rigorous monitoring plan to match it.
Now, hearing all of this, the vehicle testing, the soaking, the week without a shower for patch testing, the pelvic exams, it begs a really obvious question. Why does this massive monitoring burden fall entirely on the individual specialist and the patient? Why isn't there a standard safety net?
The short answer is a fundamental lack of standard regulatory oversight. And this is the exact issue where the medical community is sharply, deeply divided on the use of compounded bioidentical hormone replacement therapy, or CBHRT.
Let's lay out both sides impartially, based on our source stack. On one side, you have the proponents, the compounding pharmacies, specific integrative practitioners, and thousands upon thousands of patients. They argue that CBHRT provides essential, highly individualized care.
Because women's bodies are not identical.
Exactly. A woman might have a multifaceted presentation, maybe severe dryness, but also vulvodynia chronic pain, and a documented allergy to a preservative used in every single FDA-approved commercial cream.
For that specific patient, the commercial, fixed-strength options simply fail. They have nowhere else to turn. Proponents argue that compounding allows a clinician to remove allergens, adjust the dose down to a micro level, and combine therapies, like the estrogen and lidocaine we discussed, into a single life-changing treatment. To them, it is the ultimate expression of personalized medicine.
But on the other side of the divide, you have the major established medical bodies. The British Menopause Society, the Royal College of Obstetricians and Gynecologists, the FDA in the U.S. They have issued stark consensus statements strongly warning against the use of compounded bioidentical hormones.
Their concerns are rooted in the very nature of how compounding works. Because these bespoke creams are mixed individually, batch by batch, in independent pharmacies, they are not subjected to the rigorous, large-scale human clinical trials required for FDA approval.
Right.
The medical societies warn that this lack of oversight means there is no standardized data on efficacy, and critically, no guaranteed data on safety.
They also raise alarms about the potential for inconsistent dosing, meaning the cream you get in January might technically have a slightly different strength than the refill you get in March. They also cite risks of impurities, lack of sterility in some facilities, and the complete absence of standardized safety labeling that comes with regulated drugs.
Furthermore, the experts from these medical bodies strongly warn against a specific diagnostic practice often associated with compounded hormones, which is using saliva tests to determine these customized doses.
Right, because proponents often say, we will test your saliva and make a cream tailored exactly to your deficit. Why do the guidelines reject that?
Because of the biological mechanism of how hormones travel and are absorbed, hormone levels fluctuate wildly throughout the day based on stress, diet, and circadian rhythms. More importantly, the concentration of a hormone found in the salivary glands does not correlate to the cellular uptake of that hormone in the target tissue, like the vulva.
So it's not a one-to-one match.
Not at all. The major societies state that testing saliva to dictate a precise, micro-customized cream dosage is scientifically unreliable and clinically invalid. You are basically aiming at a moving target in the dark.
So, if the major medical societies are sounding the alarm about safety and unregulated testing, but individual patients are finding profound, life-altering relief through these highly personalized creams when everything else has failed, where does that leave you, the listener, if you are navigating the incredibly difficult symptoms of menopause?
If we connect this to the bigger picture, it places the ultimate responsibility squarely on the relationship between you and a highly qualified prescribing specialist. This controversy explained exactly why the rigorous monitoring playbook we've been breaking down, the base testing, the soak and seal, the patch testing, the routine pelvic exams, why none of that is optional.
Mandatory.
Exactly. When you step outside the bounds of standardized, FDA-regulated therapies, that rigorous, hypervigilant monitoring isn't just good practice. It is an absolute clinical necessity to ensure your safety in unregulated territory.
So, what does this all mean? We started this deep dive looking for a simple cure. A custom cream to fix the devastating, painful symptoms of declining estrogen. But we found that when you choose a bespoke compounded medication, you aren't just buying a product. You are entering into a highly active process.
You are stepping out of the role of a passive patient and taking on the role of a clinical monitor.
Exactly. You are tracking your symptoms daily. You are trying to figure out the subtle differences between the burning of tissue atrophy and the burning of contact dermatitis. You are going through the tedious steps of vehicle testing on your forearm or enduring a week without a shower for patch testing just to isolate a solvent that is stripping your skin's lipids.
Still a lot of work.
It is. Personalized medicine sounds incredibly glamorous on paper, but in practice, it requires hypervigilant self-monitoring, and most importantly, it requires a healthcare provider who actually listens and pivots when your skin raises a red flag.
Which brings us to a crucial question for the future of healthcare. As medicine pushes further and further into the realm of hyper-personalized, custom compounded treatments, not just for hormones, but for specialized skincare, for targeted anti-aging, for everything, will our body's unique, individual sensitivities eventually render standardized, one-size-fits-all FDA approvals obsolete?
That's a huge question.
Right. Or is the risk of navigating this unmapped Wild West of individualized medicine, where your cure can become your allergen, too high a price to pay for the perfect bespoke prescription?
It really makes you wonder. I mean, if the treatment for the symptom perfectly mimics the symptom itself, the only way out isn't a better cream, but a better detective. Keep an eye on the evidence, keep an eye on your own skin, and we'll catch you on the next deep dive.